world is to identify people with fracture. They've told us that they need to be treated, yet we are not doing that. Not more than, if you look at women over 67 with a fracture, it's less than a quarter of those women are treated, which means 75%, three-quarters are not. They're not being diagnosed. They're not being treated.
So they're just suffering as hurting individuals?
Well, some of them are suffering, and they may assume that their pain in their back, for example, is just back pain in its old age. Or their physicians say, well, that's a disease, or they assume it's a disease of aging. It's really something that in 2017 not only is manageable, but it's also preventable. And we want to get the message out to patients that you need to be proactive with your physician to ask about osteoporosis. This is, when you're outside and you're on the way to the mailbox and have a trip and fall, that wrist fracture is not simply because you had a bad fall or because you slipped. It's most likely going to be because your bones were brittle, and it's as we said, a way of knowing you're at risk and you need to get treated.
What are the treatments that you talked about awareness and then assessment, personal awareness, and then in the industry? But what are the treatments that we can look for?
I think the good news we have is it's manageable.
Okay.
First as a starter. The good news is we have a diverse menu of individual therapies that we can offer our patients. And I think that as a clinician, what I want to do is individualize the therapy based on the evidence, based on my judgment, and based on patient preferences. This is a unique time in history when we have all these therapies available to individualize for our patients. The problem is, as you pointed out, can we get them full access to those therapies? And the therapies they want and their phisians want.
To many of us think, you get diagnosed, your doctor recommends a treatment, you get the treatment, you can feel better. But you're saying it's a lot more complicated than that. These are the development, the emergence, and the reality of what we call the barriers to access. You are on the front lines. You see these barriers to access. What are we talking about?
Well, if I see a patient, for example, at highest risk, that patient I want to use a bone formation agent that's going to add new, quote-unquote, younger bone to that patient. I'm going to rapidly correct it because they might be at risk, 10-15% risk of a fracture in that first year after a fracture. I want to correct it as fast as I can. Both I want to do it, but my patient wants to do it too. Having a fracture once, that's a once-in-a-lifetime experience you don't need to do again. And we're talking here about risk could be 10-15% in that first year. So I think, but then the question is, we think that, and we know that that might be the best path for the patient, but payers, insurers would certainly prefer, since many of these newer drugs are more expensive, that we start with a less expensive drug. And they're certainly going to make hurdles, so you have to fail the less expensive drug. And you then maybe fail an intermediate expensive drug to get to where the patient should be from the get-go.
What does winning look like for the osteoporosis world, physician, patient, and innovation?
Well, to use a Rodney Dangerfield thing, we need more respect. And we need respect in the community, from fellow clinicians understanding osteoporosis, as we said, is serious, it's deadly, has consequences, but we got therapies. We need respect from patients to understand that they need to know that osteoporosis is really preventable and manageable, and if they have a fragility fracture, even if their physician hasn't told them about the therapies, they need to demand, talk to me about ways I can help my osteoporosis. So I think, and then as clinicians, we need to get more respect from payers and insurances that we understand the needs of our patients. Judgment really for our patients does depend on the literature, and doesn't really, I don't think, depend as much on guidelines, but the literature, my experience with colleagues, it depends on my clinical judgment and my conversations with the patient. I want to do what's right for my patient.